Hello and welcome to part 1 of module 1 on electrolytes and acid-base imbalance. I know that you guys have talked about electrolytes in J1. We're going to just do a review and go in a little bit more depth and tie in electrolytes into acid-base imbalance. And then I will record a separate session to talk about acid-base imbalance. So these are the outcomes for module 1. I just took them directly from Blackboard if you'd like to review them. All right, let's talk about electrolytes. So important electrolytes to know: sodium, potassium, calcium, magnesium, phosphorus. You need to commit the normal lab values to memory. You will be asked questions that expect you to know what those normal lab values are. And then when you actually get into practice, it's important for you guys to know what these normal labs are, because you're going to be using them often. And it's really important in the care of your patient. So go ahead and make sure that you have these normals memorized. The gold standard is the values found in a Lewis textbook. So just make sure that you're referring to that for your information. Okay, so let's talk briefly about hypernatremia, so too much sodium, okay? It means that you have too much sodium in the serum. It can be caused by a couple different things, including inadequate water intake, or excess water loss, or sodium gain. So either you're not getting enough water, so you get concentrated, you have lost too much water, so same problem, different mechanism, or you've gained too much sodium. All result in the same sort of issue. It does cause hyperosmolarity, so lots of particulates, which means the cells themselves get dehydrated. The primary way your body fights this is thirst. So it makes you thirsty, so you drink water, so you don't get this hyperosmolarity. Manifestations. So we already talked about thirst. Also, when it gets bad enough, you can have changes in mental status, anywhere from drowsiness to restlessness, confusion, lethargy, and then degrading further into seizures and even coma. And all your symptoms are related to fluid volume deficit, okay? And the way that we take care of this is we treat the underlying cause. So whatever the underlying issue that started in the beginning, we're going to fix that. So for this case, it's going to be replacement of fluids to dilute or get rid of the excess sodium that you have in your body. Okay, hyponatremia, so not enough sodium. So two main causes of hyponatremia: either you're losing sodium containing fluids or you have too much water. So same problem, just different mechanism. And the way that you can lose sodium is through sweating, because you don't just lose water, right? You lose salt too, which is the whole reason things like Gatorade were created. And then diuretics can also cause this. And then nasogastric tubes. So this is the tube that goes in through the nose, down into the stomach, and sucks out gastric secretions for people that have guts that either need rest or aren't working adequately. So you're sucking out excess acid is basically what happens. But you're also sucking out the sodium. So what this looks like in your patient, mild manifestations would be things like headache again, irritability, difficulty concentrating, and then when you get more severe, confusion, vomiting, seizures, and coma. So your brain really doesn't like when you don't have enough sodium or too much sodium. Hyperkalemia, so this is too much potassium. And this is going to be a really important thing when we start talking acid-base imbalance. So different causes of high serum potassium. The primary one that you're going to see over and over again is renal impairment. So your kidneys aren't working correctly, and that causes these high rises in potassium. And so when we start talking about doing dialysis on our renal patients, one of the reasons that we're doing that, besides just getting rid of toxins, is to control the serum potassium level. And there's this shift from the intracellular fluid to the extracellular fluid that can also cause it. If you take in too much sodium, that could be a cause, although that's rare. And some drugs can also cause hyperkalemia. It's most common, again, in your renal failure patients. And then manifestations. So this shows up as cardiac issues a lot of times. So dysrhythmias are a huge problem. So irregular heart rates or heart rhythms that can be dangerous. Also, you've got fatigue and confusion. You start having some muscle issues like tetany and cramps. You can even have weak or paralyzed skeletal muscles. And then you start throwing in some GI complications as well, including abdominal cramping or diarrhea. And hyperkalemia is tied in with acidosis. So when we start talking about acidosis, you're going to see high potassium levels that go along with that. And then why potassium is important. So it does have these negative effects on the heart. And so one way that we measure how the heart is working is through an EKG or ECG, same thing, just interchangeable terms. And so what happens on the ECG is that you start getting these changes that can cause these dangerous arrhythmias, okay? It's not important that you memorize these specific changes that you'll see, but just know that it starts messing with it. So the top one is what a normal one would look like. When you start talking hypokalemia, you start getting these changes in that complex that's after the spike, so ST depression, and that can be problematic. And then you start getting these tall peak Ts when you start talking hyperkalemia, and it can just lead to lethal arrhythmias. So why we are so hyper-focused on potassium. One of the most dangerous arrhythmias that it can cause is VFib. So VFib is basically when your heart is just kind of quivering, the whole thing, which is basically cardiac arrest and death. So anyways, potassium is really important, and if your heart can't beat correctly, then you can't survive. So. All right, hypokalemia. So that's low serum potassium. So a couple different things that can cause it. Either we're losing potassium from our kidneys that are just dumping it, or the GI tract. We talked about things like diarrhea, or if we're doing some suctioning. We could have a shift of K from the extracellular fluid to the intracellular fluid. We could have a dietary potassium deficiency, although that's very rare, or we're losing potassium through our kidneys because we're diuresing, and so the potassium gets taken with it. So what does that show up as? The cardiac, again, complications are the most serious. Things like decreased blood pressure, a thready or weak pulse. Again, you can have VTAC, and VTAC is a lethal heart arrhythmia, of course, that can cause death. So again, potassium affects the way that the heart works. You can also have that skeletal muscle weakness of respiratory muscles, so you can't breathe adequately, decreased GI motility, you can have hyperglycemia, and then some neuro complications like altered mental status, anxiety, confusion, and again, we got coma. So really important for you to know what medication is most often talked about when we're talking about hypokalemia. So it's a certain diuretic medication, and there's this whole class called potassium wasting. So it's our old friend furosemide. So whenever we're talking about giving Lasix or furosemide, we always have to keep in mind what our potassium level is because we don't want it to get dangerously low. So whenever you're giving furosemide in the hospital, it will ask you what the last potassium level is because you don't want these to get too low. And then hypokalemia is associated with alkalosis, so a pH that's too high. So A high potassium is associated with a low pH or an acidotic pH, but a low potassium is associated with a high pH or alkalosis. So something important to remember. Okay, so you need to know the same sorts of things for calcium, magnesium, phosphorus. We're not going to go through those, but make sure that you look those things up in your Lewis book. When we are talking about calcium imbalances, you've got Trousseau's and Chebyshev. I can never say them right. That you'll find whenever you have imbalances of calcium. And then magnesium here is Trousseau's. So it's another heart arrhythmia. If your magnesium gets imbalanced, you can get this lethal arrhythmia called Trousseau's or Torsades de Pointes. That is not compatible with living. So important for you to maintain your magnesium level. So make sure you do spend some time looking at those things because you're responsible for knowing them. All right. And here is a little practice question for us. We have a patient who is admitted with renal failure. So let's think back. What was the electrolyte imbalance associated with renal failure? Can you remember? Potassium, right? And what happens with our renal failure patients? Do they have potassium that's too high or too low? Too high, right? Okay, and then they have an arterial blood pH level of 7.29. So we're going to learn that 7.29 is actually a low pH. So as we talked about before, I told you guys to remember that high potassium levels are associated with low pH levels. Okay, so which lab result would we expect to see? So we're going to go through these guys. So we already talked about how renal failure patients have an issue with potassium. And whenever we have high potassium levels, we expect low pH levels, or low pH levels, we expect high potassium levels. And the correct answer is C, serum potassium of 5.9, which is an elevated serum potassium level. All right, that's it for this recording. We will move on in the second recording to acid-base imbalance.